They're hiding actually. So he's mad. So the bee should come out. Okay, so let me. Okay, please come out. Med one, Dr. Alcover. Dr. Alcover, Med one, please get out there. Okay.
Yes,
Hello,
Doc.
hello. Med
Hello,
one.
Doc.
So, hello, doctor. So here are for medical interns and medical clerks. Our first reactor is actually a Med one. Okay, huh? So don't. I can hear your heartbeat beating, Dr. Alcover. Just relax. Just relax. Okay, huh? So the bee actually won't. Actually, the cobra won't kill you.
You're
Actually,
good, Doc.
the cobra just want to greet you a Merry Christmas. Actually, huh?
Merry
So
Christmas to.
Merry Christmas also. So Merry Christmas everyone. Merry Christmas, Dr. Alcover. So actually, this is a bonus question for you. Kasi actually the urinary, this is a urinary bladder actually, ha? So this is for all of you, ha? So just wait. So this is a urinary bladder. So this is not the usual actual bladder, but usually when you see a urinary bladder that is filled with urine, because this is contrast filled. Actually, you injected a dye or a contrast to this area. That's why it is turned white with because of the contrast media. But generally, if you try to look at it, the urinary bladder is supposed to be, doctor, if it is filled, it is going to be that way, di ba? The urinary bladder. So if it is filled, normally it is filled that way. But look at this, it is inverted as if the tip, this one, the apex is here already. So it's an inverted, an inverted one because there's a problem here actually in this urinary bladder. So it's like a Christmas tree. So you see you can see this output chinks, Dr. Alcover. Can you see this one, Doctor? Dr.
Yes, Doc.
Alcover. So these are output chinks. Huh? So meaning that there is a chronic inflammation that has been happening to the urinary bladder, which we call a cystitis. But there has been a cystitis actually, but much more than that, that is something bizarre. So aside from the infection, they develop also diverticles going there. And then actually, uh, the wall is thickened actually in this. This is the wall of the urinary bladder, and this is the mucosa. Actually, you are just staining the mucosa, Dr. Alcover and other doctors there. You don't see actually the wall, the muscular wall, huh? Because in the contrast actually the material would just cover up or would just paint white the mucosa. Okay, so this is like a Christmas tree. So where do you see this one? The Christmas tree urinary bladder is usually seen uh, in neurogenic bladder. Neurogenic bladder, or if there could be a bladder neck obstruction as well. For example, a bladder neck obstruction here. For example, there could be a stone here. So the urine could not get out. So definitely, you will always be having a chronic infection of the urinary bladder because imagine the urine couldn't get out. And later on, because of the chronic infection of the urinary bladder, you develop actually a destruction of your wall, of your urinary bladder. So you have that appearance, bizarre appearance.
Yes,
So,
Doc.
so let's discuss what is a neurogenic bladder. So medical interns and medical clerks and everyone. A neurogenic bladder is actually a name given to a number of urinary conditions in people who lack bladder control due to a brain, spinal, or nerve problem. This nerve damage can be the result of diseases like multiple sclerosis, Parkinson's, or diabetes. What are the symptoms of a neurogenic bladder? The symptoms are feeling of a sudden urgent need to urinate, frequent urination. Diba? Actually, we can see that in patients, they're here in Everim's or RTR, or even actually in our lolos and lolas when they're all very, very old. It seems that sometimes they cannot hold anymore their urine. They just, you call that as, what do you call that one, Dr. Alcover, in which the a patient or your lola just cannot hold the urine, because immediately would urinate. Incontinence, di ba? Urinary incontinence, di ba? Ito, immediately would the urine would just get out. It could be one of the symptoms of neurogenic bladder. However, look, therefore, inability to control urination. But sometimes, in other patients, there could be inability or difficulty of urination. So look at that. So you have here two extremes. It could either be a neurogenic bladder could either be that the patient continues to urinate, just cannot control, could urinate immediately, urinary incontinence. Or it could be that the patient actually loves to urinate but cannot urinate simply because as if there's a paralysis of the urinary bladder muscles. So it's either that the patient cannot urinate or could urinate too much. They're just too extreme. So that is a neurogenic bladder.
Yes, Doc.
And how does it develop? Hello? Hello? Can you hear me?
Yes, Doc.
Okay, so how does it develop? How did it develop, this one, the Christmas tree urinary bladder? Okay. So a Christmas tree bladder or pine cone bladder is a cystographic appearance which is usually seen in severe neurogenic bladder disease with increased sphincter tone. It's not pathognomonic, it is not pathognomonic, meaning it is not very specific that if it is, you consider it is due to a specific disease. It can be due to many causes and may also be seen in bladder neck obstruction due to non-neurogenic causes. So if you try to look at this, doctors, so this is the way how our micturition is controlled. So, for example, the parasympathetic, the parasympathetic fibers, di ba? The effects of parasympathetic fibers are that, for example, it will increase your the bowels, di ba? Will increase the peristalsis of your bowels, and then it could also increase the peristalsis of your detrusor muscles of your urinary bladder. That's why with you, the tendency would be, if it is already filled, the urinary bladder is already filled, there are stretches up there. So the tendency would be for your detrusor muscle to contract so that urine will get out. Okay, so that it's granting if it is an intact parasympathetic. Okay, so these are the way by which we can control. This is just an example. You don't have to memorize this one. I'm just trying to show you. So it could also be, so there are factors. So you should avoid that. You should have an intact parasympathetic parasympathetic fibers. You should also have an intact sympathetic fibers. You should also have an intact muscle. This one, the muscles, diba? So, and then you should have also an intact brain, because this one, of course, the sensing would go to here and then would be registered in the brain, and it would send signal for you to urinate if needed. So therefore, this is the one that is being summarized. So the pelvic nerve, the parasympathetic and opposed impulse result in this detrusor contraction of your muscles during parasympathetic. Then we have hypogastric nerve. The sympathetic inhibits the detrusor muscle contraction during feeling and contract muscles in urethra and neck. That's why in sympathetic naman, it is actually the relaxation of your bladder. So you should have an intact sympathetic, you should have an intact parasympathetic, and you should have an intact pons, because it's the one that switches between feeling, storage, and voiding. And you should have an intact cerebral cortex, because it's the one that interprets messages are full of empty bladder. So if you have strokes, if you have cerebrovascular diseases, you'll really be having a neurogenic bladder. That's why you notice that some of your patients would usually be, it could either be that they cannot urinate or they would just urinate immediately. So what is a neurogenic bladder? Therefore, it is a condition caused as a result of some type of a problem with the nerves whose function is to control the urinary bladder. So therefore, the problem lies here. So any of those involvement depends would lead to neurogenic bladder. Okay. So, for example, if the problem here is that the innervation in the absence, if for example there's a problem here, you will have a neurogenic bladder. Okay. So if you also have a problem above the level of the conus medullaris, you'll have also a neurogenic bladder. So innervation in patient with below at the level of the sacrum, you also have a problem. So it's either that you will have always be urinating, you will always be urinating, you cannot control, you always urinate. For example, if the problem is above the level of the conus medullaris, you will have that problem. Or if you have an innervation with below the level of the sacrum, you cannot urinate. You cannot urinate. So therefore, neurogenic bladder is either that you cannot control your urination, you immediately would urinate, or you cannot urinate. It depends upon the level of the problem. Huh? Okay. So what are the symptoms therefore of the neurogenic bladder that produces the so-called Christmas tree urinary bladder? Urinary incontinence. That is, you always have that you cannot control. Even for just a small volume, you immediately urinate. Huh? So urinary frequency, repeated UTI. Repeated UTI simply because, for example, if you have this one, you cannot di ba, you for example, if you have a bladder that does not respond to stretching simply because you have a problem below at the level of the sacrum, you have a problem. So you are already feeling your urinary bladder, but you just cannot urinate simply because there's a problem. So the patient is already angry because it is you have already filled urinary bladder, but you cannot urinate. So therefore, aside from the damage that you are producing to your patient, you will be having frequent UTI as well. Because remember, the stasis of the urine is so big here. So your frequent UTI. So if you have a frequent UTI, definitely, what will happen to your muscles of your to your mucosa and your muscles of your bladder? You'll definitely destroy this one because of the infectious process as well. So therefore, you will have a Christmas tree urinary bladder. But if you will have, for example, this one also, Dr. Alcover and the rest of you, if you have this one, if you always urinate, you cannot anymore wait going to the comfort room. Just like, for example, with our old people, our lolas, diba? You cannot anymore wait. So therefore, you will be waiting a lot always of your of your for the lolas, the vagina, diba? And then to think that they have a very small the female, they have very short urethra. Okay, so definitely if you will be wetting always, they will always be wetting your the blanket, and then the pantry. And if you will have, you say you put a diaper, you should put a diaper, but you remember the diaper will absorb also the germs, so definitely you will have a recurrent UTI. So that's the problem here. Okay, so that's why you will have recurrent UTI. Definitely you will have a destroyed urinary bladder appearance. So therefore, you will have a Christmas tree urinary bladder. Okay, can you get me, Dr. Alcover?
Yes, Doc.
And the rest of the medical students out there. So, okay. So, urinary urgency, urinary retention. Again, it's either that there will always be urinary retention. That's why you put a catheter, doctor. You put a catheter because there's urinary retention. Your patient is mad already. Or so you will put a catheter. Again, with the catheter, another infection again. So, and then here naman, you can have urinary incontinence frequency. So this one, urinary incontinence frequency falls at this level. This one. And then for the urinary urinary retention, it falls for this one. So it depends upon the level of the destruction of the nerves or of the nervous system. So
Yes, Doc.
okay, so we go na. Okay, so again, it's just the same, huh? Lesions below S1, lesions above C2, then okay, at the brain. So therefore, a bladder dysfunction, the neurogenic bladder causes flaccid or spastic. Flaccid, the one that is distended, that you cannot urinate because always distended. A spastic is the one that incontinence. You cannot hold all your urine, always urinating. Huh? So that is flaccid or spastic bladder. At first, before, actually, many when I ask my medical students, they cannot just immediately express what a neurogenic bladder is. So I always specify. They're always thinking that it could either be that it's always incontinence. No, it could either also be that you cannot urinate. That is also neurogenic. You can also that you will always be urinating. So that is neurogenic bladder. It depends upon the level of obstruction or destruction. Okay. So I just would like to share this one also. The trigon. The trigon is a favorite board exam question. What is the trigon? The trigon is actually, for example, this is the urinary bladder. Diba, the trigon. The trigon is the one that the triangle that is formed from the right ureter, the left ureter, diba, the orifice, the opening of the ureter here, this one, that one, and this one, the urethral orifice, this one. So, the triangle that is formed there is that trigone. So, that trigone kasi is very, very sensitive to stretching. That's why when it's already filled, and when you touch this one, when this already the urinary bladder is already filled, once this is touched, this is very sensitive, the trigone. So therefore, you would like to urinate immediately. So the trigone, therefore, is a smooth triangular region of the internal urinary bladder formed by the two ureteric orifice and the internal urethral orifice. The area is very sensitive to expansion, and once stretched to a certain degree, the urinary bladder signals the brain to void or to be okay, So don't forget about that trigone. That's very important. Okay. So we will be going now to the next topic actually, but I will have a but that I would like to note, this is because this will be related to our next topic, the vesicoureteral reflux. So take note of the entry of the ureters to the urinary bladder. Take note of that. Okay. So therefore, Dr. Alcover, tell us what you know. Don't be afraid, actually. So you are at this is a blended learning. So you first year starting to learn and express that out what you learned. Fourth year naman, they're just human beings as well. They're also human beings. They tend to forget things. So it is just a review. So tell us and be proud of yourself to tell us what you know. So therefore, the reflection questions before we begin are the lecture proper is, what is hydronephrosis or pelvic and what are common causes that you know?
Hydronephrosis or pelvocalctasia is the dilatation of the renal pelvis due to the accumulation of urine fluid.
Yes,
And
correct.
the common cause of this is renal stone obstruction.
Good. Okay. So other causes that you may also, it could be that, for examples, here's where the mentor enters. Okay. Look at this. You correct, Actually, very good. What you said was correct. For example, at the left, if you have stones, if you have a stone here at the ureterovesical junction, di ba? If you have a stone here, so definitely it will be blocking the flow of urine. So it will go up, di ba? It will go up. That's why the urine will fill your, as you said, your pelvocalicial system or your renal sinus, di ba? It will fill. So it will fill with urine. That's why you become hydronephrotic, hydro water, di ba? Or it could be that, for example, Dr. Alcover, are you married already? Not yet.
Ah,
Not
hindi
yet?
pa, Dok.
Oh.
Hindi pa,
So
Dok.
for example, not yet. So therefore, before I proceed, who is your virtual crush in Med 1? Huh? Virtual. Huh?
Aray
Who
pa,
is your
Dok.
virtual crush? Huh?
Wala pa,
Okay,
Dok.
so don't you try to find, it's about time, di ba? Now is the time to find virtual girlfriend. Okay? Okay, so okay, doctor. So, for example, if you are a pregnant woman, di ba, when the baby is developing at the pelvic region, it can compress your
Yes, Dok.
ureter. So actually, you will have actually a physiologic hydronephrosis actually in pregnancy. Yes, huh? Or, for example, doctor, and to all of you, you know, the ureter baya, once, di ba, it is going there, the ureter epiphysis, actually, it has a physiologic valve. A physiologic valve, an anatomic valve is, for example, this is just an example, an anatomic valve is that you really have a valve. You really have a valve. So, for example, in veins, di ba, in veins, the veins, di ba, in veins, di ba, it's going towards the heart, di ba, the veins. They going towards the heart. The arteries are going away from the heart. The veins, they usually have a valve. They usually have a valve. They have a valve so that when your blood flows going there, it will not usually go back because of the valve. The valve helps in the uplifting of your blood going. That's why if you have an incompetent valves, for example, if you try to look at your legs, if you have incompetent valves, you will develop varicose veins. Di ba? The varicose veins, di ba? You
Yes, Dok.
remember?
Yes, Dok.
Because they have incompetent valves. So these are examples of anatomic valves. This is an example of the lymphatics, di ba? The lymphatics you have discussed, di ba? You have read that one, di ba? They have a valve. Okay. Okay, so this one, the ureter, at the end point of the ureter here, they have a valve, but actually it is a physiologic valve. Meaning, a physiologic valve, they don't have that really, the so-called valve, but it is a physiologic valve. Meaning, if for example, you are already filled here, di ba? Why is it that normally, di ba, normally, if we are already filled with urine, in our urinary bladders already filled with urine, we love to urinate, but at least, di ba, you can control muna for some time. You can control until you can find a CR already, di ba? You remove your urine. But normally, even though this is filled, it is not just that you develop UTI, urinary tract infection, simply because why? Because actually the for example, just make an imagine that this is going to be there, di ba? This like that going to be there. This portion actually is below the mucosa. Is at this one here. Is here, not inside, of course. It is here, somewhere here, Okay, so they go there. They have a physiologic valve, meaning not anatomic valve. So meaning if you are filled already with urine, the urine actually does not immediately reflux going up, because that would be bad if it will be refluxing immediately, So simply because this one closes. Actually, when it is already filled, this one actually closes. This one closes, This one closes so that the urine here would not go there. Because if you will be doing that way, you will be going that way, the dirty urine would be going back to your kidney, and your kidney will develop, of course, pyelonephritis or infection of the kidney. And then because of the pressure here, you will develop hydronephrosis, di ba? Because it will be going up, Can you get me, Dr. Alcover?
Yes, Doc.
Okay. And Med 3 and and Med 4 and the medical interns, So that's one that if you have actually a problem in your valve, in your ureteral valve, ureteral, physiologic ureteral valve, then you develop ureterovesical reflux. Thing that we will discuss later on. You usually encounter so much about ureterovesical reflux in infants and in children and even in adults as well. Okay, ha? So that is one cause. Another cause of hydronephrosis. Another cause is, for example, doctor, you have a tumor. If you have a tumor that, for example, is growing and it covers the urethral orifice, definitely you will have a backflow, because this will you will have difficulty urinating kasi. Or if you also have a tumor somewhere here that will obstruct the ureter, you will have hydronephrosis. Or example, doctor Alcover, you're a male. You're a male, ba?
Yes,
You're a
Doc.
male? Okay,
Yes,
very good.
Doc.
Okay. So, Dr. Alcover, so, for example, you have an enlarged prostate gland. Enlarged. Di ba? The prostate is under, di ba? It is under the urinary bladder, the prostate gland. If it keeps on enlarging and enlarging and enlarging, very big, it will compress your prostatic urethra. Remember, the urethra is composed of, di ba, the penile, the bulbar. Important in the board exam, they question this one, ha? The anterior urethra is composed of anterior portion of the urethra is composed of the penile. Then it is composed of the bulbar, okay? Anterior urethra. Then the posterior urethra, anterior urethra. The posterior part of the urethra is composed of your membranous portion here, and then the prostatic urethra. Again, doctor, what are the components of the anterior urethra? Answer: prostatic and bulbar. What are the components? What are the components of the posterior urethra? Membranous. And then the prostatic urethra.
Yes,
So
Doc.
if this is your prostate that has become enlarged, therefore it will compress, doctor, your prostatic urethra. So therefore you will have a blockage of your urination. Okay, that's why if you remember your father or your tiyo or your lolo, they have an enlarged prostata. My prostate gland daw is enlarged. I find it difficult to urinate, 'di ba? So they will say that once. So it's because of that, and eventually when they will they will go to ultrasound, majority of them, if the prostate is already so big, they will develop hydronephrosis in X-ray, in ultrasound. We will see
Yes,
that
Doc.
later. So those are just actually the many examples. So okay, next. So the next reflection question. So you answer this one, correct? Okay. So what are the three normal anatomic ureteral constriction, and what is the importance of knowing them, doctor? Sige, go.
The three constrictions are the uteropelvic junction, and the second is the crossing at the bifurcation of the iliac vessel, and the
Okay.
ureterovesical junction.
Okay, very good. Okay.
So
So,
it
okay, in
is
relation to that, okay,
it
so what is the importance? Okay.
importance to know them is to know where the renal stones lodged or something
Okay.
like
Okay.
that.
Oh, okay. Very good. Correct. You answered this one. Very good. So, when a renal stone falls down, the entire ureteral length, what normal anatomical ureteral constriction area would it lodge most commonly?
At the ureterovesical junction.
Very good, because it is the narrowest. Ang galing naman ng first year na to. You join na lang the fourth year na. You join the B2 club na. This is the B2 kasi, group B2. So, very good, ha? Okay. You keep it up, ha? Si potential ka to, eh. Potential doctor ka talaga. Okay, what are calcium stones And what are calcium stones and Staghorn calculi radiopaque, meaning visible in plain X-ray, and hyperechoic in ultrasound as well? True or false?
Yes, Doc. They are
Okay.
visible or true.
Okay, okay, visible. So, uh, therefore, calcium stones, di ba, calcium stones, calcium, para ba't calcium? Sabi mo lang calcium. Kay, it's struvite stone is also a radiopaque. Majority, 90% of struvite stones are radiopaque, di ba? So, calcium stones. So, correct. Okay. You can see them actually both in X-ray and in ultrasound. Correct. So, are uric acid and cysteine stones radiolucent, meaning not visible, or if ever, sometimes they can be visible but very, very faint in plain X-ray, and hyperechoic in ultrasound, meaning they can be seen as well in ultrasound?
It is true, Doc.
Okay, correct. Okay. So, uric acid, they could be hardly seen, or sometimes they cannot really be seen at all in X-ray, but actually in ultrasound, they can be seen. So, therefore, ultrasound is a better modality actually in trying to visualize stones. So, don't forget, therefore, uric acid, di ba? Uric acid, cysteine as well. Correct, So, therefore, you mentioned about Staghorn, the struvi, the, the Staghorn. What is a Staghorn calculus? What is its chemical composition? Why does it develop during urinary tract infection?
Staghorn calculus, it is a calculus that takes shape the renal silus and takes shape also the major callus.
Mm-hmm.
And as it takes shape, it resembles the staghorns in the reindeer ba yun?
Mm-hmm. Correct. Okay,
And
correct.
its chemical composition is the MAP, magnesium ammonium phosphate. And
Okay.
it develops in urinary tract infection because the magnesium ammonium phosphate, um, they precipitate in a alkaline environment. And
Okay.
in urinary tract infection, especially what you said previously, Doc, is the Proteus bacteria.
Mm-hmm. Oh,
They
yes.
they manifest an alkaline environment. And if there is an alkaline environment in a urinary tract infection, then the magnesium ammonium phosphate crystals will encourage to form a calculus or to precipitate.
Okay. Okay. Oh, so very good. And then to add it up, di ba, the Proteus, di ba, from the name itself, Proteus, di ba, Proteus, they are urease producing, di ba? They are urease producing microorganisms, di ba? Di ba yung medtech, di ba? The Proteus are urease producing microorganism which converts urea to
Ammonia.
ammonia. Ammonia. And actually, this it reacts actually with another hydrogen to become ammonium. So, di ba, the
Yes, Doc.
ammonium? That ammonium is actually what makes it the alkaline environment. The
Yes,
ammonium. So
Doc.
therefore, as you said, because of the alkaline medium brought about by this one, from urea to ammonia to ammonium, brought about by the Proteus, which is a urease producing, the environment now becomes alkaline, as you said, and they precipitate.
Yes.
And therefore they become stones. Very good, Doctor. So number 6, correct. Perfect ata. So, what pathologic condition can you see the cobra head deformity in intravenous pyelography, ultrasound, or CT scan? Sige.
Urethrosil.
Okay, very good.
And if meron urethrosil, there's a uretero-vesical reflux.
Yes, yes. Wari ko pa nga mention yun, nasabi mo na. Okay, very good. Yes, you will know more later on, pero actually very good, in one cause of actually of urethrosil is when you develop yes, so sige lang. Very good. Okay, actually. So you get perfect 7. So, wow, very good, So, med 1, congrats. Okay, med 1. Okay, med 1. Okay, hands up. Okay, good. Okay, so, very good. Okay, so, thank you, Dr. Alcober, Thank you. Very good. Keep it up. Okay,
Thank you, Doc.
Okay, welcome. Okay, so, let's review what Doctor said, So, therefore, Therefore, review na tayo, ha? So, if you make this one, this coronal section of a kidney, look at this, ha? So, di ba, so, remember, these are the renal parenchyma is composed of the cortex and then the medulla. And this one, according to Dr. Alcover, he was mentioning about the, di ba, the pelvis, the renal pelvis, and then the calyx. Okay. So this is the pelvis actually an expansion of your ureter, It's an expansion of your ureter. So the pelvis, of course, they collect the, di ba, these are the minor calyces. They become the major calyces, di ba? Minor, the major calyces, and therefore they will be collected. They will be collected going to the ureter. Okay, and remember, so that the urine can be transferred here, di ba? This is the, di ba, we have here the medulla, and we said that the medulla, they contain the collecting ducts, and then the loop of Henle, di ba? The loop of Henle, di ba? And then the loop of Henle. While, so the loop of Henle, they are components of the nephron, di ba? And then the collecting duct, for other physiologists, they are part of a nephron. For other physiologists, they are that part daw. So whatever it is, three common portions of the nephron are present. So they are the renal corpuscle, di ba? The renal corpuscle, which is composed of the glomerulus, and then the Bowman's capsule B, and then the tubules, which is composed of the proximal convoluted, the distal convoluted, and then the distal convoluted tubules. So usually the proximal convolute, the renal corpuscle, the proximal convoluted, proximal convoluted, distal convoluted, they are usually, and then they are usually here, and a part of the collecting duct. You're usually here in the cortex. Okay, but if usually those, di ba, especially if you are mentioning, there's a collecting duct, because remember, we also have the cortical nephrons here, which is the most abundant, di ba? Cortical nephrons, 90%. Remember, juxtaglomerular nephron, it is here only. So therefore, the one that goes down deeper are the portions of the juxtaglomerular, and they are the loop of Henle, and then the collecting duct. So remember, although this is fewer in number compared to the cortical nephrons, the juxtaglomerular, this is very popular, the juxtaglomerular, in as much as this portion, the loop of Henle, and then the collecting duct, this one, the loop of Henle, especially with the vasa recta, of course, I'm assuming that there's a vasa recta there, they are the ones that are involved actually in the concentrating ability of the kidney, and through the process of the countercurrent flow and exchange, or countercurrent mechanism. That's why it is more popular, because the concentrating ability is here. So therefore, this one is a portion of the cortex, that because the medulla actually is this one, but because of the presence of the renal column of Bertins, which are actually extension, this favorite board exam question also, the renal column of Bertins, they're extension of the cortex. So they're divided they divide therefore the medulla into medullary pyramids. So remember that therefore, if you have the collecting ducts here, they will, of course, this is of course the renal papilla. This one, the blind ending of the medulla is the renal papilla here. So remember, the collecting tubules will be going there via the cortical tubules will be going there. So therefore, the collecting ducts will be going there. So therefore, the urine that were collected from the filtration process here, they will be going there to be excreted out by the body. So therefore, diabetes, they try to victimize this renal papilla. That's why toxins would accumulate, simply because they're supposed to be filtered out or to be excreted out. They cannot anymore because they destroy the papilla. So remember, the renal papilla. So granting this a normal papilla, Look, the collecting ducts will be going there, and they will be going here to the minor calyces first. Then they will be collected the major calyces, then they become to the pelvis. So therefore, no wonder this portion of the kidney is ultrasound plus, remember, you have here, Doc, what are the other structures here? What is this? The fats. So therefore, you call therefore this one as the renal sinus. This is the renal sinus. The renal sinus therefore is composed of the fats, the minor calyces and the major calyces, including of course the nerves and the vessels here that enter. Diba? This is the renal hilum kasi. You'll also enter the renal veins here. Oh? The renal arteries, the renal vein, and then the nerves. So therefore, this structures composed of calyces, the pelvis, according to Dr. Alcover, plus the fats. You call this as the renal sinus. This one, that's why this one, they have fats here. So this is the renal sinus. So this one. So these are there for the collecting ducts here going there. So this is the renal papilla. So the minor calyces become the major calyces, then the pelvis, renal pelvis, plus the vessels and nerves. So therefore, you call this area overall as the renal sinus. In ultrasound, di ba, you have seen it to be very bright, that one. That bright area or hyperechoic is very echogenic ba? Echogenic, echo, it's white. It is therefore the normal sinus. Okay, the normal sinus. So it is presumed that this one, di ba? This is the transverse cut naman, the cross section. So of course, it's the pelvis here, the renal pelvis. So supposed to be the renal pelvis here. Okay. Now, as long as it is not hydronephrotic or there is no pelvocalectasia, or hydronephrosis, it is like that because this is the normal one. Okay, ha? But if, for example, there is hydronephrosis or pelvocalectasia because there is an obstruction, whatever it is, could be a stone, could be a congenital stricture of the ureteropelvic junction, could be to prostate gland enlargement, or to a tumor in the urinary bladder, whatever it is, it will cause pelvocalectasia. This is the pelvocalectasia. If there is an obstruction already. So whatever the cause would be the obstruction, this is the pelvocalectasia or synonymous with hydronephrosis. Okay, ha? So it could be mild, it could be moderate, it could be severe. So therefore, this one is urine. The black thing that you see is the urine. So therefore, let's go back here. So therefore, this is the normal. It is very echogenic. This is the normal one. Okay, so we go down. So therefore, sinus fat, because this is the sinus. Okay, composed also of the calyces, like that. Okay, the blood vessels, the hilum. That's why this is the one. Okay, white, hyperechoic. And this one, the medulla. So this is the renal column of Bertins. Okay, so Dr. Alcover, are you still there? Hello, Dr. Alcover?
Yes,
Hello.
Doc.
Okay, so Dr. Alcover, kindly tell us, all of us, the doctors, even in front of you, give me structures now that you can see here on the medulla. The nephron.
I can see medullary pyramid, the renal column of Bertin. I see the cortex. I see
So
the
this one is the cortex. This is the renal column of Bertin. This is the medullary pyramid, di ba?
yes,
Okay.
Doc.
So, for example, for example, we go to the microscope. What microscopic structures can you see here within the within the medullary pyramid here?
The nephrons, Doc.
What particular nephrons? What portion?
At the
No. What portion of the nephron can be seen specifically within the renal pyramid?
Loop of Henle.
Oh yes, very good, loop of Henle. And
collecting duct.
Yes, collecting ducts. Because I told you, for other physiologists, they consider also the collecting duct as a part of the nephron. Other naman physiologists, they say, don't include the collecting duct. Whatever it is, you just try to, yung Guyton kasi, he considers collecting duct also as a part of the nephron. Sige lang, basta.
Yes, Doc.
Okay. But you do not see the renal corpuscle in the medulla. No, you only see it here in the
cortex, Doc.
You also see this proximal convoluted tubule also here, di ba? And
yes,
then the
Doc.
Convoluted only in the cortex. But,
yes, Doc.
But collecting ducts, you can actually some portion of the proximal, some portion of the collecting duct, and then the loop of Henle can also be seen at the cortex if they are the cortical nephrons, right?
Yes, Doc.
Okay, but if the juxtaglomeralular nephrons, they are here. That's why when they descend down here, the deeper portion of the medulla, it is only the loop of Henle that you see and the collecting ducts, diba?
Yes,
okay,
Doc.
Very good. Okay, so continue. So there's a normal, There's a very normal. Okay, so you at least you don't be afraid. You don't have to be afraid now, Even though you may say a wrong thing, no problem. You have already made a perfect thing. So, okay, so here. Okay, so this is therefore the renal pelvis. The renal pelvis, So they become the major calyces, then the minor calyces. So this is the renal sinus fat. Okay, Okay, this is the renal sinus fat. Okay. So, wow. Dr. Alcover, do you see already sort of a pelvocalectasia here?
Yes, Doc. The blackening.
Yes, very good. I told you, join the 4th year na, doctor. So you skip 2nd year, 3rd year na, just joke. Okay, So good, very good. Okay, so this is the So this is the remember always, this is the ureter. I always tell you now, all of you, the ureter, if it is not dilated, you cannot actually see the ureter in ultrasound, simply because the overlying air, bowel gases, actually, the bowel gases kasi, they look white kasi in ultrasound. They look white like this. They can obscure the ureters. Because the ureters are normally filled with water, di ba, urine. That's why it's black. But because of the overpowering of the gases, they tend to be obscured normally, Dr. Alcover and the other doctors,
Yes, Doc.
But if they are dilated because there is an obstruction somewhere there, the distal portion, they can now become visible. If there is an obstruction already, they become visible now. Meaning to say, if you see the ureter like that, it is already dilated. Okay. Doctor, can you get me?
Yes, Doc.
Okay, sige, very good. Okay, So wow, so there's a pelvocalectasia here, So these are actually the minor calyces, doctor, and all of you, that were already dilated. This one, and these are the major calyces, and this is the renal pelvis already, and this is the ureter. So therefore, you have a dilatation of the central echo complex. Normally, in ultrasound, you term this one as your central echo complex, simply because it is very, very white. Meaning to say that is an intact renal sinus. So, Dr. Alcover, take note of that.
Yes, Doc.
When you go for your chatting with your med one, you tend to discuss, you tend to practice what you said ba. The best way kasi of learning is to talk about it always. To talk
Yes,
about
Doc.
it all. Then you can teach your fellow med one, including na Dr. Alcover. Hello?
Yes, Doc.
Including your virtual crush.
Patay.
Okay, yes, you can do that. No problem. You're a normal guy, man. Okay, so, okay. Sige, go. Okay, ha? Sige, so that's a normal one, ha? Okay. Sige, very good. Okay, so, wow. So, now, according to what you said also, the film findings. So, you said that calcium stone or astrovite stone, astrovite, the magnesium ammonium phosphate or the Staghorn calculi, di ba? Staghorn calculi, astrovite stone, they're just the same terms, ha? So, or magnesium ammonium phosphate stone, the infection stones. We say infection stones simply because usually they develop during recurrent urinary tract infection, wherein, like for example, the microorganisms like Proteus, they are urease producing microorganisms which converts the urea into ammonia to become an ammonium, and that ammonium is an alkaline medium, so therefore making the crystals precipitate. Now it makes more sense because diba, you were a medtech before, diba? You're a medtech graduate, diba? And you were having stone analysis, diba? So you now know how actually stones are formed. Huh? Okay. So with, for example, this one is in the plain film. In the plain film, you see this one. What do you
Yes,
think
Doc.
is that? What do you think? Is it a simple stone made up of calcium only, of a simple stone, or do you think it is a staghorn? This one. What do you think is this? That's the shape.
Um, it's not a Staghorn, Doc.
Huh? This one?
Calcium yata, Doc. Calcium
This one
stones.
is a calcium. This one is a calcium. Actually, this is already in the ureter. This one is in the ureter actually, this one, huh? It is presumed to be in the ureter. This is the kidney because diba told you, this for all of you, don't worry because this for all, that's why we are here. Look at what did I tell you before. The level of the kidney is at the level of the T12 to L3. So this is the T12. This is the T12. This one. This is the T12. If you see this one like a longer rib, post rib, that's the T12. So if this is the T12, T12. So this must be L1, lumbar 1, 2, 3, 4, 5. Correct. This is a 5 because this is already the sacrum. This is already the sacrum. This is the sacrum. Huh? Okay, Dr. Alcoba, this is sacrum. Huh?
Yes, Doc.
Can you get me? Okay.
Yes, Doc.
Wow, advanced topic, ha? So, as I told you, kaya nyo yan. Kayang-kaya nyo talaga yan. Only that you just you really need guidance. Okay, so this is the sacrum. So, T12, I told you, if you try to look for the kidney, the shadow of the kidney, you look for T12, L1, L2, L3. They are usually there. So, this is the one. This is the renal shadow. This one, can you see this shape? This is the renal shadow.
Yes,
Okay,
Doc.
so they are there. So that one, look at this. Look at the shape. They look like the staghorn. Diba? They look like the staghorn. This one. This is a staghorn actually. This one is a most likely a calcium stone because it does not form like a calcium, but it does not form like a staghorn. But usually you see them both. Huh? But what is important is you see this is the psoas muscle. This is the psoas muscle. Okay. This is the psoas. This one.
Yes, Doc.
Okay. This one are your vertebral bodies, the lumbar. Okay, this is your pedicle, the vertebral pedicle. This is the spine. Actually, look like that is you expand your image. This is just an X-ray. So look at that. So this is this is intervertebral disc space. This one, intervertebral disc space. This is your transverse processes. This one, transverse processes. Okay, huh? This is your iliac bone. This is your iliac bone. Okay, this is your sacrum. Okay, so go. That is. So, what do you think is it? Is it a staghorn?
Yes, Doc.
Yes, that's a staghorn. It assumes the shape I told you about. It assumes the shape of the pelvo. Look at this, the pelvo calicial system. Di ba? It assumes so. So it is presuming that is the medulla here. Huh? Okay.
Yes, Doc.
Okay, so that is actually, it assumes, you told me, a staghorn assumes the shape of a pelvo-calicial system. Oh, that's why it looks like that. Okay, so that's it. Huh? That is not a ginger. So that is that is a Staghorn, ha? So look at that, ha? So this is your ureter, this is your pelvis, doctor. This is
Yes.
your calyces, ha?
Yes, Doc.
And this pressure, that is your medullas here. Okay, ha? Because you do not stain your medulla there with the contrast because if this is a contrast, diba? So this is also another Staghorn calculi on the other side. Huh? If you try to look at that on ultrasound, okay. Anyway, that is another Staghorn. Huh? This another Staghorn on in X-ray. Huh?
இல்லடா 12 மணி வரை இருக்குல்ல நான் ஜேர்னல் வர தேடிட்டு இருக்கேன்.
So this is the one, ha? So then on ultrasound, Dr. Alcover, are you there?
Yes, Doc, I'm here.
And other doctors. So this is a Staghorn on ultrasound. Doc,
Yes.
Doc, I find it difficult, Doc, to understand because, Doc, in this one, I can see well. This is the pelvis, this is the major calyx, the minor. But here, Doc, I find it confusing because I can see only because it is being obscured by the shadow. Huh? This is kasi the shadow of the stone. Huh? Actually, the stones are there, only that they are shadows. I will explain to all of you actually for the next time why a typical stone, whether a stone in the kidney or a stone in the urinary and the gallbladder would develop a posterior sonic shadowing. It's a posterior sonic shadowing. And you will only learn that if we will try to discuss why is it that in pleural effusion, di ba, you have an example in pleural effusion. Why is it that the pleural effusion in X-ray is white? But why is it that in pleural effusion in ultrasound, it is black? Di ba? You have seen examples of that one, di ba? So, I will explain some other time, ha? But it's important now for you, Med 1, and then the Med 4, and then the intern, is that just try to look at the lesion with familiarity so that you will learn from it, and then later on, you will na lang justify what made it that one, ha? Some next sessions na lang. So what is important is this is a shadowing. The shadowing kasi obscures these portions here, ha? But what you see are this one, are this one. Can you get me? Ha, doctor? Ha?
Yes, Doc.
While supposed to be these areas here are obscured only by the shadow. So that is a Staghorn. Okay. So that's one. This was obscured by the shadowing here. Well, you see this one. Okay, ha? So therefore, a Staghorn calculus, because it is like the Staghorn of the deer. Okay, ha? Or it is also like the shell, the Staghorn seashell, like that in the aquarium, di ba? So therefore, Staghorn calculi, also sometimes called as coral calculi, are renal calculi that obtain their characteristic shape by forming a cast of the renal pelvis and calyces, thus resembling the horns of a stag. They refer to struvite also they'll call it struvite calculus involving the renal pelvis and at least 2 calyces. So, general discussion, Staghorn calculi are the result of recurrent infection and thus more commonly encountered in women. So those with renal tract anomalies, for example, ureterovesical reflux, spinal cord injuries, neurogenic bladder, or ileal ureteral diversion, you can actually commonly see Staghorn calculi that develop. So, di ba I told you, neurogenic bladder are prone to recurrent urinary tract infection, so they will develop Staghorn. Also with reflux, because if, for example, you will have always a urinary bladder, and if the ureter, and you have an anomaly here of your physiologic valve here of your ureter. So, natural, the urine would reflux going back, and then it will have an infection of your kidney because they will go back there. So therefore, you will develop Staghorn calculus simply because you have recurrent urinary tract infection. So majority of Staghorn calculi are symptomatic, presenting with fever, blood in the urine, hematuria, flank pain, and potentially septicemia and abscess formation. Okay. So staghorn are composed of struvite. Chemically, the struvite is actually MAP, magnesium, ammonium phosphate, and are usually seen in the setting of recurrent UTI with urease-producing bacteria. They are the Proteus, Klebsiella, Pseudomonas, Enterobacteria. The urea that they produce hydrolyzes the urea to ammonium with an increase in the urinary pH. So therefore, they will precipitate. So struvite accounts for approximately 70% of the composition of this calculi and is usually mixed with calcium phosphate. So around majority of the struvite stones or the MAP are actually opaque. However, because they are usually mixed with calcium phosphate. However, sometimes kasi in very few instances only, uric acid and cysteine are underlying components of the minority of this calculi. That's why they cannot sometimes they cannot be seen. Although majority they can be seen because usually they are coated with calcium. So the vast majority of Staghorn calculi therefore are radiopaque and appear as branching calcific densities overlying the and mimic an excitatory phase. So this one. Okay. The collecting system is filled with a densely calcified mass producing marked posterior sonic shadowing or posterior sonic shadowing. That's what I mean. The shadowing ba? This
Yes,
one.
Doc.
This one. Okay.
Posterior acoustic
Shadowing. So, doctor, my challenge for you, you try to Google search, doctor, ha? What you read for yourself, then maybe sometime with our bed one to tomorrow for our class. What is the difference between posterior sonic shadowing from posterior sonic enhancement? Actually, they're different. When posterior sonic enhancement is the shadow of posterior sonic enhancement is like white. So usually, for example, if you do an ultrasound and you happen to see a water density, like for example the urine in itself, the shadow that is casted there is white. That's what you call as posterior sonic enhancement. And
Yes,
if for example if you have a stone, the shadow that is casted there is black. That's why you call it posterior sonic shadowing. It has
Yes,
something to do, doctor. It has something to do with, therefore, add in your reading for tonight. What is ultrasound? How is an ultrasound generated? On reading lang. I will explain it also tomorrow, of course. On reading lang so that a good student kasi is one who advances as well. So, you read mamaya, what is the principle of ultrasound? It is a sound. It is actually a sound. You just read the best that you read from Google searches, you know how to do a Google search, and
Yes,
then I will enhance you all tomorrow, the all med one, just for, of course, we will have topic tomorrow, of course, the absorption, the secretion, the countercurrent, but a 5 to 10 minutes will be, of course, a point for reflection. Anything that goes, that as long as it is very good related topic, that would be very good. So I will do it tomorrow also. But for your part, you just have advanced reading. Okay,
yes,
so
Doc.
okay, so continue. So that is a simple stone. Look at this, doctor. Look at this. This is actually a kidney. This is a kidney. This one, the shadow that you see, it's a kidney.
Yes, Doc.
Just wait, So that is a simple stone. That is not a Staghorn type. So that's a calcium. Okay. So in ultrasound, you see that one, So that's the one that you see here. Okay. So this one, Doc, this is partly obstructing. Look, the stone is here. The stone here is here. So partly it is obstructing because you can see the a black part here. That's how urine. Meaning to say, it is partly obstructing. It is at it is almost at the level of the renal pelvis. This one. Okay.
Yes, Doc.
So, okay. So
എനിക്ക് ഏതെങ്കിലും കേസ് ട്രാൻസിയന്റ് ടക്യൂട്നി കിട്ടിയില്ല.
Uric acid
നിയോനാറ്റൽ
stones.
ട്രാൻസിയന്റ് ടക്യൂട്നി
So uric acid stones. About 8% of renal stones contain
കേസ്
uric
കിട്ടിയില്ല.
acid. Majority are those with calcium, but may be associated with hyperuricemia, with or without gout. So those with having increased uric acid, they can develop uric acid stone. They form in acidic urine, these uric acid stones. That's why for one of the treatment therefore of uric acid stones is to make your urine alkaline.
അതന്നല്ലേ?
Yes, Doc.
So general appearance, small friable yellowish, may form staghorn. They can also form staghorn in shape. Radiolucent. Di ba I told you kanina, majority of the staghorn are radiopaque because they are usually coated with calcium. But some kasi, some minority, very, very small amount, a very small minority can form radiolucent staghorn because they are now filled with uric acid instead of the calcium.
Yes, Doc.
Okay, so they visualized but they can be visualized by ultrasound or IV pyelogram. So this is an example, for example, of a uric acid stone. So how do you develop uric acid stone? Uric acid stones form in acidic urine, pH of less than 0.5, 5.5. Dietary urine intake and endogenous uric acid production from urine turnover will increase uric acid. So cystine stone, so uric acid. So cystine stones are also radiolucent stones.
Yes,
So,
Doc.
okay, so cystine stones form in patients with stenuria, condition, struvite stones. So struvite or MAP or the infection stones, majority are radiopaque. 90%, 10% could be radiolucent. So usually they can be seen because they are calcium coated. But if they happen to be uric acid coated, they cannot be seen. Okay, so struvite stone form as a result of urinary tract infections with urea-splitting bacteria such as Proteus, Klebsiella that produce the enzyme urease. The increased urine pH increases therefore the risk of struvite stone. That's what you said. Okay. So uric acid stones are radiolucent on plain films but can be visualized on CT and X-ray. Prevention and treatment involves alkalinization of the urine to pH 6 to 6.5. So at this point, I will call a medical clerk. So thank you, doctor, Diyan ka lang, standby ka lang. So how about you, doctor, medical, I'll call a medical clerk na, So Dr. Darren, Dr. Gloria. Hello, Dr. Daria. Hello, Dr. Darren. Hello, Dr. Darren.
Good
Dr.
morning,
Darren.
Doc.
Good morning, Dr. Darren. So, what is ACALCA? What is ACALCA? What is the composition of ACALCA?
What's going on, everyone? Jim here.
Sige na, you Google search. What is ACALCA? Di ba usually you give ACALCA daw for stones, for those with kidney stones?
And I literally defended her in the first.
So, what is ACALCA? What is the component of ACALCA? Sige, you try to Google search.
ACALCA is a potassium citrate, Doc.
What does it do? Would it increase the alkalinity of the urine? What is the indication? What is the mode of action of ACALCA?
Massive sale at this place. You already know. I've got cyberpunk ones behind me. I have 5 of my own designs. I'm going to leave a link in the picture down below. Right click on it. Pick up some displays today. Support the channel. And also make a great gift here. Now, Pokemon, who has said
ACALCA, Doc, is a potassium citrate. It is used to make the urine less acidic or...
Meaning to alkalinize the urine. Di ba? To alkalinize, it makes the urine less acidic. Pardon?
It helps the kidneys to get rid of the uric acid.
Okay. It also tends to make the urine less acidic.
Less acidic, Doc.
Oh, so therefore it tries to alkalinize the urine.
Yes.
So Therefore, uric acid kasi they have the tendency to precipitate in an acidic environment, right? So therefore, in order that you try to avoid the uric acid to precipitate, you want to make the urine alkaline, di ba? So that is therefore one of the good effects of a calca. Ha? Aside from trying to decrease the uric acid, it also tends to make the uric acid less precipitate to become a stone. Ha? So therefore, if you try to look at this one, doctor, alkalinization of the urine to pH of 6 to 6.5 increases uric acid solubility. Therefore, I just explain naman, nagtitilipon ako, sandali lang ha. Hello. Good morning. Hello. Hi, Dr. Bilang. May lecture na ako Zoom. May lecture ko kasi Zoom. Hindi na nakapatunan yun. May lecture na ako medical students. So, hay na ka mga tungod. Hay na ka mo. Pwede, no problem. Alas na. Nag-text ako actually kan Sergeant Paraon. Say ko 12 pa ka niya balay. Bisa 12 pa ka nila. Kaya maupo nila kayo pagbalik. Ha? So, ano yung problem, sir? Bakit doon na mo nila balay? Maupo load gani kayo. Kapabalik ako ng LFC. May lecture lang ako. Sige, sir. Thank you very much, ha? Bye-bye. Hello. So Dr. Darren, very good learning, di ba? Very good learning. So this is really blended learning. That's why I ask you. Actually, I ask you this one. Actually, not answer. What is the purpose of that akalka? The akalka, you told us that it will tend to lower as well the uric acid, but it also the same time it tends to alkalinize the urine. It tends to lessen the acidity because the acidity kasi is a culprit because it tends to precipitate the uric acid, right? So therefore, if you try to look at that one, so alkalinization of the urine to pH of 6 to 6.5 to increase uric acid solubility. Therefore, uric acid will not precipitate to become a stone. So alkalization consists of oral potassium citrate. Then actually, Dr. Gloria, Dr. Darren, it is already, the answer is actually there already. so calca therefore is potassium citrate, ha? Okay, 10 to 20 ml equivalent 2 to 3 times a day, ha? So it usually months ganit pag-administer, di ba? You administer it for months, di ba? So oral potassium citrate 10 ml 2 to 3 times a day. So adequate hydration to reduce therefore supersaturation. A low animal protein diet is recommended to reduce acid production. So dietary sodium should be restricted to reduce urinary uric acid, to reduce urinary acid excretion. So okay ha, so it's very very clear, doctor ha. Okay, we go. So we go next. So therefore, standby lang, Dr. Agarens, because it's not, we will now be involving the rest of the medical works. So hydronephrosis, therefore, a problem in the urinary tract keeps urine from draining properly, causing the kidneys to fill with urine. Ha? So therefore, again, as told to Dr. Alcober, hydronephrosis developed actually when there is water, urine, hydro, that accumulates actually in the renal pelvo-calyceal system for many causes. It can be from an obstruction somewhere there in the ureter or in the urinary bladder, and could be from stones, could be from urinary bladder tumor, could be from ureterovesical reflux. Huh? So, and other causes. Oh, so, for example, you have a problem here. So, look at that. You will have a dilatation. And then, at first, important first to you to know, at first there could be an enlargement of the kidney. Yes, correct. Because if you will be filling with water, you can enlarge the kidney. But later on, actually, don't be surprised. You will have a hydronephrotic kidney filled with urine, meaning with urine, but the kidney becomes small. Simply because pressure, di ba, the pressure that is created there. And then therefore, you will have tubular necrosis, you will have a death of your nephrons. That's why you will have into a small kidney in the end, huh? Or the so-called end-stage kidney disease, huh? Okay. So just imagine lang, if you will be compressing this one, di ba doctors, you have there the vasa recta, di ba, then your urinal vasculature, the capillaries. So you will end up in a end stage renal disease. Huh? Meaning end stage, the kidneys are small already. Doctor? Okay, so we continue. Therefore, the bladder is empty. Then the pressure is transmitted to the kidney, then there's a buildup of fluid in the kidney. So according to Dr. Alcover, there are 3 constrictions at the ureteropelvic, at the crossing of the external or common iliac artery, and at the site of the entrance to the bladder, or the ureterovesical junction. This is the smallest. This is the smallest diameter of all the 3 junctions. That's why stones tend to lodge here. Okay, so this is the adrenal gland. Okay, so kidney stones, can become lodged at these constrictions. So I would like you to reflect na this time. Aside from those stones, you will try to reflect. Okay. Another cause for hydronephrosis, as I told you, causes are stones, could be from, okay, so doctor, I'll call on for one of the medical clerks. So, Dr. Igano. Hello, Dr. Marisol. Hello. Dr. Marisol, good morning. Okay.
Good morning,
Hello.
Doc.
Okay, good morning. So, is your daddy still playing lawn tennis in Tacloban City Tennis Club? Is engineer?
Yes po, Doc.
Okay, very good. Okay. So Dr. Marisol and the rest of you, so di ba I told you one of the causes for hydronephrosis would be stones. Okay. It could either be here at the ureteropelvic, here at the middle portion. It could be here at the urerovesical. But the most common in the board exam, it's always being asked, is at the ureterovesical junction because it's the smallest diameter. It could be pregnancy, or it could be also a mass, diba? That will try to, or a prostate gland enlargement. Okay, it will try to block this the urethral orifice here. Okay. Okay, so now let's focus ourselves. Look at this. The uretero, this one. The drainage area, but here, sorry, the point, the end area here. Try to look at this, at the ureter. As I told you, it has a physiologic valve. It has a physiologic valve, meaning not anatomic, but a physiologic valve, so that when it is already filled, it tends to constrict so that the urine will not immediately go. Any deficiency or any problem on there could mean a primary cause of ureterovesical reflux, a frequent cause of urinary tract infection, recurrent, especially among newborn, infants, and children. Okay, so Doctora, so what do we mean, therefore, Doctora Marisol, by ureterovesical reflux? This is a favorite board exam question. Again, this topic. Ureterovesical. It means a retrograde flow of urine from the urinary bladder into the upper urinary tract due to incompetent vesicoureteral junction, meaning the physiologic valve is incompetent. It cannot just constrict. It usually opens. That's why you will have a backflow going there. VUR is important because of its association with the renal dysfunction and parenchymal scarring in UTI. Remember, if you will always be subjected to always an infection because of urine going there, you will destroy your kidney, diba? So in the end, if you will be chronic destruction, you will have end-stage renal failure. Okay. What are the causes? It could be primary or secondary. When we say primary, the most common cause is a lateral ectopy of the ureter. But this one is lateral ectopy. It is also actually associated already with the development also actually of a incompetent valve. You will see that one later on. Huh? Then another cause is a posterior urethral valve. Look at this. Normally, it does not have a valve. This time, it is an anatomic valve. There is a valve that obstructs there. So, anatomic valve, posterior urethral valve. If you have a valve there, it will block your flow of urine from the urinary bladder going to the urethra. Therefore, if it is there, you will have a vesico-ureteral reflux. Okay. Congenital neuropathic or neurogenic bladder. Diba? I told you, neurogenic bladder could either be that the patient cannot urinate because of a detrusor muscle, for example, flaccidity. If the detrusor muscle is flaccid, it's always dilated there. It cannot. Therefore, urine would backflow. Congenital urethral stricture. If this will be small in caliber, which can be seen also among children. There are children actually who say, hello, Dr. Marisol, hello? Dr. Marisol.
Yes, Doc.
I don't know if you have encountered this case, but you can actually see this in children. Children who are playing and they say that, ate, doktora, I find it difficult to urinate. My wee mechanism daw is slow. Meaning they can urinate but not that fast ba. So you try to watch out for that because that kid might be complaining later on of recurrent UTI. So you try to think of, is this having a stricture, congenital stricture of the urethra? And it usually happens. We have patients on that in AVRMC. So they have recurrent UTI, and then when we do a vesico, with we have a thing kasi that's so-called voiding cystourethrogram. Voiding cystourethrogram is an important, actually a very popular thing requested, that you request for patients that you are suspecting of vesico-ureteral reflux. In voiding cystourethrogram, you put a dye ba? You first let the patient urinate first. You let the patient, and then later on, when the urinary bladder is already empty, you put a dye from here going there. Once it is already filled, you tell the patient, I will put a dye. Once this is already filled, and you say that, di ba, you will be filling this slowly, and then later it will fill. You tell your patient, little boy, once it is already, you feel already the tendency to urinate because you were feeling, kasi once you have already felt the tendency to urinate because it's being filled, tell us, then you will urinate. Don't be ashamed. You just urinate in front of the rad tech or in front of us. You just urinate, and then when you try to urinate already, make already a shot of the X-ray. Make a shot. Once the baby is already urinating, try to make a shot. Because if you have a vesico-ureteral reflux, di ba, supposed to be the baby you'll be urinating. Yes, the baby will urinate. But if it is a reflux, one, you notice immediately in the fluoroscope that there will be a reflux. If that reflux is only up to that point only, it did not reach your pelvocalicial system, that is grade 1. Grade 1, uretero, up to the ureter only. But if, for example, further, you have noticed that once the baby was already urinating, aside from the reflux, it went pagod into the pelvocalicial system, but not necessarily dilatation. It reached only the pelvocalicial system, but no, actually, no dilatation yet of the calyces. So that is stage 2. If you develop stage 3 is when it also reached the pelvocalicial system, but there seems to be mild dilatation of the calyces. That is already stage 3. Stage 4 is further clubbing of the calyces, stage 4. And then stage 5 is the worst, really big clubbing. So that is stage 5. What is important here is that if it is stage 1 or stage 2 only, you notice it is only stage 1 or stage 2, then that the baby can still go into spontaneous resolution of the vesicoureteral reflux. But if it is already stage 3, stage 4, stage 5, the patient should be operated. Huh? Okay, so we go further. So, Dr. Marisol, hello. Hello,
Yes,
Doctora.
Doc.
So thank you.
Yes,
So I will call. Thank you. I will call on Dr. Carlo. Hello, Dr. Carlo Badilla. Hello, Dr. Carlo. Are you there, Dr. Carlo? Open your video and your mic. Dr. Carlo. Absent. Dr. Carlo. So
Yes, Doc. Wait, Doc.
you're there. Open your mouth. Open your mouth. Open your camera. Open your camera. And yun. Okay. I want to see you again because you might be 2 times double in size na. Okay. Sige, okay. Sige. Okay. Open, okay. Sige, good, okay. So, we continue actually with VUR, ha? Because it's a very important topic, ha? This is a ureteral vesical reflux. I tell you, it's a favorite board exam question also because it is usually you see them, ha? As a case. So, okay. What is really the normal? What is really the normal entry of the ureter going to the urinary bladder? Look at this. The normal, as it goes there, di ba? As it goes there, okay? As it goes there, normally, it is like this, doctor. Like this. It is long and it is oblique. This is the muscle, this is the mucosa, this is the submucosal area. Mucosa, submucosal, this is the muscular area. Look at this. It is long, and it goes oblique. An abnormal one is this, that it is short. Okay, it is short. So, the ratio of the tunnel, so you have a tunnel here, di ba? The ratio of the tunnel to the diameter of the ureter should always be 3, meaning tunnel should be, the length should be 3:5. In others, 5 pa gani. 3:5 is to 1, meaning the length should be bigger in number compared with that of the diameter. So normally 3:1. So again, if you have a long tunnel, meaning 3:1, longer length, at tapos it's pagod in oblique, and then a small diameter, 3:1, you should have no reflux. But if you have a medium tunnel, possible you can have a reflux. But if you have a short tunnel simply because it's like that, it doesn't go into obliquity anymore. Short, definitely you'll have reflux. Okay. So, as I told you pagod kanina, it is not only the lateral ectopy. This is the so-called lateral ectopy. Look at this. It's like a lateral ectopy because supposed to be, if it is long, diba, it goes into medial, lateral. But if it is only lateral ectopy, meaning it is only here. On this side, like this. It's short man. Okay. So, that's what it means here. So, there is lateral ectopy here. That's a problem. So, meaning to say that the physiologic valve does not close. If it does not close, simply because you have a lateral ectopy or a short tunnel, the tendency you will have ureterovesical reflux. Okay. But if you have a long tunnel like that, the tendency would be the physiologic valve to constrict. So that when it is fully filling with urine, this is being filled with urine, it just cannot go out immediately simply because this close. So the normal functioning of the physiologic valve is associated actually with a normal tunnel length. Can you get me, Dr. Carlo? Can you get me? Okay, so okay, we go, Okay. Another is the presence of a posterior urethral valve. That's a problem. Okay, normally we do not have a posterior urethral valve. This is the urethra. Normally, we do not have. But if you have a posterior urethral valve, for example, you have a valve there, that is something crazy, that is bad. Because it will be obstructing the flow of urine. So that's why when you did a contrast study, you placed, diba, you placed a dye from this granting that this is the penis, diba? Okay, it's the penis. So this is your urethra, diba? So if you're penile, it is your bulbar urethra. Supposed to be granting, example lang this is the prostate area, granting to be, so there's the prostatic urethra. So you see this one, Dr. Carlo? Can you see this one? A filling effect. That means to say that is the valve. That is the valve. So just imagine you will be obstructing that the flow. So therefore the urine flow. So therefore it will go back. It will go back. So you will have a ureterovesical reflux. Okay, Then another point of knowledge. Doc, what are other causes, Doc, of ureterovesical reflux? Congenital. Other congenital anomalies, like for example, secondary, it is secondary or secondary to procedures, di ba? Ureteral myotomy, unroofing of ureterocele, failed ureteral, that's a secondary because secondary to a surgical manipulation. But for the primary or congenital, there are causes: lateral ectopy, posterior urethral valve, congenital neuropathic bladder, congenital urethral stricture. There is still important ureteral duplication. You know what ureteral duplication is? This is the one. Maybe the first time that you heard, it is a phenomenon. It happens. It happens in EVRMC. It happens in other hospitals. It happens in Philippine Children's Medical Center. It is a real phenomenon. There is double ureter. So, it is a congenital anomaly because you know what? We only have, okay, I will include here in the game. You don't stand by lang don't off your camera. I'll go back to Dr. Alcober. Join the game. Dr. Alcober, are you there?
Yes, Doc.
Go back. Okay, open your. Diba, open your video camera.
Diba,
you told us, sige lang. I can see you, no problem. Diba, you told us that you only have one pelvo-calycial system. Diba, right? Diba, you remember? One ureter, because the calyx is the minor, becomes the major calyx is the minor, then become the major calyx is then becomes the, diba, becomes the pelvis, diba?
yes,
right?
Doc.
It becomes the ureter. But mind you, I tell you, there we have congenital anomalies in which you have two ureters and you have two pelvo-calycial system. or collecting system. Ha? Pelvo-calycial system or collecting pareho. Duduha. They are two. And it is the upper pole moiety here because it's the upper pole of the kidney. This is the lower pole. So Dr. Carlo
Yes.
and Dr. Alcover.
Yes, Doc.
Upper pole, lower pole. So therefore, this is the upper pole moiety ureter. This is the upper pole moiety ureter. This is the lower pole moiety ureter. So what do we mean by Weigert-Mayer rule? Weigert-Mayer. So you can ano ha, you do a Google search on that, Dr. Mamaya ha, Dr. Alcover. Mayer rule. In Weigert-Mayer rule, it applies to a rule in double collecting system or double ureter. It is said now that the upper pole moiety ureter goes medially in reference to the lower pole moiety ha, goes medially and inserts to the urinary bladder inferiorly. Again, the upper pole moiety ureter descends medially and inserts to the urinary bladder inferiorly in reference to the
Lower pole.
lower pole moiety. Now, the lower pole moiety ureter naman descends laterally and inserts superiorly. Superiorly with reference to the upper pole moiety. The upper pole moiety is prone to the development of the cobra head deformity that you see, meaning it is prone to the development of obstruction, while the lower pole moiety is prone to the development of uretero-vesical reflux. Again, I do not forget this one because for me, before kasi I tend to forget which is prone to the development of obstruction or ureterosil or the cobra head. Is it the upper pole or the lower pole? Diba, one technique, Dr. Carlo and Dr. Alcover is, Dr. Carlo, if Dr. Alcover, hello?
Yes, Doc.
Andyan ka?
Yes, Doc.
Ano,
Yes, Doc.
what is the character, what is the usual character of a person who has superiority complex? Dr. Carlo. A
Opo.
person who has a superiority complex, di ba, mahilig siyang mambara. Mahilig siyang mang-obstruct ng tao, ng rights, di ba?
Yes, Doc.
A person who has a great superiority complex loves to obstruct someone in his rights. Even though one is right, the superiority complex person will say, "You're wrong. You're goddamn wrong." So, mahilig siyang mang-obstruct. Ha? So, the superior pole moiety is prone to obstruction. Therefore, the development of ureterosil. Ha?
Yes, Doc.
While the lower pole moiety is prone to the development of ureterovesical reflux. Ha? So, okay. Weigert-Mayer rule, therefore, incomplete ureteral duplication and double collecting system, of course. So the upper pole moiety goes on medially and inserts inferiorly and is prone to develop superior obstruction. Ito man here. And ureterosis formation, of course. The lower pole moiety labors on laterally and inserts superiorly and is prone to the development of vesico-ureteral reflux. Oh, so the superior pole moiety is prone to the development of obstruction and the cobra head, ureterosil. While this one is prone to the development of uretero vesical reflux. So, this is, Dr. Barlow, the ureterosil. A ureterosil, this one, in ultrasound, ha? This one is in KUV IVP. So, a ureterosil is a congenital abnormality found in the ureter. In this condition, the distal ureter balloons as its opening into the urinary bladder, forming a sac-like pouch. It is most often associated with a duplicated collecting system. The one, the Weigert-Meyer rule, where two ureters drain the respective kidney instead of only one. Okay, so this is the ureterosil. Okay, this one, upper pole. Okay. That is a ureterosil. That's the cobra head. That's the one. That is the cobra head. So, Dr. Carlo, it looks like a urinary bladder catheter. Di ba, Dr. Carlo? Di ba, a urinary bladder catheter, di ba, when you insert, di ba, some of your nurses here kasi, okay, and then if you have a catheter, di ba, you put a balloon so that it will be fixed back. It will be fixed there, the urinary bladder. It will not get out immediately. So to drain, di ba? Because if you have a neurogenic bladder kasi, or sometimes if you have UTI, you just cannot urinate. So you put a you put a catheter in the urinary bladder here of the patient so that it can go here. So it looks like the balloon, different you inflate kasi a balloon there so that this will not, so that the tip there of the urinary bladder catheter will not get out, of course, of the urinary bladder. So you put here a balloon. So therefore you inject a water so that, or inflate, so that you will have this is the catheter, and this is the balloon of the catheter. But you were asking, doctor, you will ask the patient, do you have a catheter, Dr. Carlo? Because you were the one ultrasound. You said, the patient will say, I have no catheter, doc. I have no catheter. Then you will be thinking, Dr. Carlo, now this time, say, what is that one? This is no catheter. So now, you don't be surprised, Dr. Carlo, if you have a case. He has no catheter, doc. Why not a catheter, doc? He has no catheter. But why is it that he has like that? That is a ureterosil. It is a congenital anomaly. Okay? Actually, in other patients, this is not symptomatic. If it's small, it is not. You have no symptoms. But if it is very big, it can have symptoms. Recurrent UTI as well. You can also have that one. Because just remember, only one ureter is functioning. Diba? So, you can develop, okay, you can develop recurrent UTI on that. So, don't forget about that, Dr. Carlo. So, that is this is a catheter. This is a catheter. But this one is ureterosil. You ask for the history, and you tell the patient, do you have a catheter? But if there's no catheter, you see that one, that is a ureterosil. Okay, Okay. So, that's the one. This is the urinary bladder, This is the urinary bladder wall, the mucosa, and you see that one. What is your time, doctor? Dr. Carlo? What is your time?
11 o'clock.
What is your time?
Look, anong time? Up to what time kami?
What is your time now? We are already up to 12.
11, Doc.
Oh, sige. Okay. Diretso na lang tayo kasi 1 hour na lang. Makatapos tayo na lang, So therefore, pathophysiology. VUR, vesicular ureteral reflux, high pressure urine into the ureters. You're putting that because of the obstruction. High pressure urine to the ureters and kidneys. Stats of urine because of postvoidal residual urine. Stats of urine good in the first infection. So therefore, low. If you have this one, your urine cannot just get out. So therefore, the urine stasis. So therefore, the urine will be there. So therefore, you will have recurrent cystitis, and it will reflux to the ureter and then go to the kidneys, diba? So you will have pyelonephritis, all of the infection in the urinary tract, you will have that one. Okay. And then if you have, therefore, don't get surprised as well that you can have stones inside. You can have stones inside this one. Why? Because the stasis of the urine, di ba? The stasis of the urine, the sediments of the urine can saturate inside. So you will have stones. Okay, ha? So again, what are the grades? Important, ha? If it's grade 1, limited to the ureter. Grade 2, up to the renal cavities without dilatation. 3, there will be dilatation of the calyces. 4, marked dilatation. 5, tortuosity and dilatation of the ureter. So it is this way, doctor. So, stage 1, if you let the patient void, the reflux would only be up to the ureter. That is stage 1. If it goes further above the renal pelvic-calyceal system, but you notice that the calyces are not yet dilated, only that it went up, that is stage 2. Stage 1 and stage 2, lucky enough because they can go into spontaneous resolution. Observe. And you can give just antibiotic muna, then periodic checkup of the patient, if it has already improved or not. But stage 3, you will develop mild pelvicolectasia, mild hydronephrosis. Stage 4, moderate hydronephrosis with tortuosity of your ureter. If it's tortuous, the more that there will be stasis as well. Backflow na, stasis pagod. Okay? If the patient wants to urinate, he can urinate, but stasis. So, if there's a blockage as well. So, stage 4. Stage 5, severe hydronephrosis plus tortuosity of the dilated ureter. So, this one, usually, surgical management. Ang stage 3, 4, and 5. So, if you have therefore neonates and infants, usually symptomatic up to 1 to 2 attacks of UTI, failure to thrive, usually. Then, fever, chills, and costovertebral angle tenderness. Then, in case of obstruction of neurogenic bladder, palpable hydronephrotic kidney or distended bladder, then in older children, urgency, frequency, incontinence of urine. So, doctor, I will call, okay, so, Dr. Carlo, thank you. So, I will call on Dr. Fema, Zurita. Hello, Dr. Zurita. Are you there?
Yes, Doc.
Okay, so Fema, do you have a camera, video cam?
Okay, I'll try, Doc.
Open plus. Sige daw. Okay. Sige daw. Okay, nadaraman. Okay, Dr. Fem, I'd just like to see also, I would just like to check you if you have already increased in size or decreased in size. Okay, the same man, maintain man, Dr. Fem. So, maybe, you're doing Zumba, no, at home. Dr. Fems. Oh, so this is the ureter, Dr. Fem. This is the ureter. Tortuous, yes. Doc. That is equivalent to tortuous. Look at that. That is tortuous, ha? That is tortuous, like that, oh. Look at that, oh. It's like that, oh. Then, wow. Look at the clubbing. Look at the clubbing of the calyces. They are already very circular. So it reminds you of this one, doctor. This one. Look at this. So he has a severe hydronephrosis of the kidney with tortuosity of the ureter. Dilated. As I told you, the ureter, as if it can be seen already, that means to say it is dilated. Normally, the ureters cannot be seen in ultrasound because they are not dilated. And they are being covered by the bubble gases. But once you see this one, big, they are already dilated talaga, the ureters. So that is stage 5. It reminds me. So look at the cortex. They're very white already. So meaning to say you have a severe scarring. Severe scarring or fibrosis of your kidney. So that end stage renal disease. What stage is this, Doctora? So when you see only up to the ureter, so you say the patient, di ba? When you put a dye to your patient, di ba? The dye is already, the dye filled the urinary bladder. And then the baby will say, the patient will say, Doc Fems, I really like to urinate because it is already failed. So you will say, okay, you urinate, but when you let the patient urinate, you now ready your camera so that you will shut the patient. So when the patient urinated, you shut immediately. But what you see is only the ureter, but you did not see dye in the kidney. So what stage is that? That is stage 1. That is still the significance is that, wow, very good. That child has still a chance for spontaneous resolution. So as a pediatrician, what you will do is give an antibiotic always, then periodic check-up of the patient, and then try to look also for follow-up if there is progression. Because usually stage 1 and 2, they can still go for spontaneous resolution. But for stage 3, 4, and 5, surgery. This one, Dr. Fems. Wow. Doc, aside from the, when I make a shot, complete shot, the patient was voiding, it went to the kidneys, Doc. But good thing is that, Doc, look, the calyces are not yet dilated. Look, normal doctors is that the normal minor callus is like that, like a teacup ba? Like a teapot, like that. They are like that. That is non-dilated pangacalysis. Meaning to say, it is not yet dilated, the pelvic-calyceal system. Only that, nag-reflux lang talaga siya. So that is stage 2. Stage 3 is this. Look at this. Doc here, supposed to be like this, di ba? Like this, oh. But look at this one, Doc. It is already flattened. So that there's already mild. That is mild pelvocalectasia. There's already hydronephrosis or pelvocalectasia, but it's only mild because the ends of the minor callus, Doc, it is flattened. Where normally kasi it is like that, like a cup. Stage 4, so surgery na gamit ito, Doc. Surgery na ito. Do not be giving your patient false hope. That is already bad. Stage 4, Doc, they are more clubbing, they are a bit bulging. So that's stage 4. And then what do you notice the ureter? They are
Tortuous na Doc.
tortuous. Okay. Wow. Ano ba yan? So this is stage 5. My God. Look at this. So that is stage 5 already. So great dilatation of the pelvic-calyceal system and grabe and ureter or dilated and they're tortuous, and then the patient cannot urinate. So you have a neurogenic bladder already. So stage 3, 4, and 5 surgery. Okay. You will see this actually in emergency. You will see them. Only that it is only pandemic. So once you get back already to your patients, we just pray for God that we can help our patients. Don't be surprised anymore if you see ureterovesical reflux. Okay? That is caused by, one, it could be congenital, Doc. The valve mechanism, the physiologic valve mechanism is not functioning, and it is, Doc, the tunnel, Doc, of the ureter is short. Diba? As I told you kanina. So it's supposed to be, Tema, it should be long and oblique. Ano?
Yes.
And and if it is long and oblique, it is already presumed as well that the physiologic valve mechanism of the distal ureter is functioning. Meaning, if it is filled with urine na, there is no backflow. There's no backflow going to, or there's no flow going towards the ureter because the valve closes. But if there is a problem, Doc, if the tunnel is short, Doc, the physiologic valve does not function properly. It does not close. So therefore, doc, when the the urinary bladder is filled with urine, the urine doc would reflux. So this one, doc, most likely congenitally the patient has a short tunnel. Only that because doctor he did not have a regular follow-up, it went into stage 2. Then later on, it went into stage 3. It went into stage 4, doc, to stage 5. So this is the consequence. Another cause is it could not be, most common is actually a defect in the urethral valve, ureteral valve, and then the length, short tunnel. Other causes, doctor, what are the other causes? For example, what do you like to see in the urethra? Prostatic urethral valve. Huh? Prostatic urethral valve. So, okay ha? So that's the normal mechanism, huh? It should have a long, and it should be oblique. It should not be short. If you have a long tunnel, it is presumed as well that the physiologic valve mechanism is normal. Meaning when the urinary is already filled with urine, it will close so that it will have no reflux. Okay. Okay. It's a normal one. This is prone. This is already reflux. So, as I told you, the presence of a congenital prostatic urethral valve is another cause. So, this is the one. So, the Weigert-Mayer rule, please don't forget about it, Doctor. But, okay, so, thank you, Dr. Afema. I'll call on another one. So, how about you, Doctor? Thank you. So, Dr. Garcia Jujane. Hello, Dr. Jujane. Hello, Dr. Jujane. Dr. Jujane. Dr. Jujane Grace Garcia. Not around. Dr. Christine Joy Israel. Hello, Dr. Christine Joy.
Hello, Doc.
Hello, open your camera. So, where are you now? What
Hello,
place?
Doc.
It's raining there? No.
Baga? No. Baga.
Okay, so don't forget about the Weigert-Mayer rule, Dr. Christine J. When you say Weigert-Mayer rule, it applies, doc, to ureteral duplication, doc. Meaning to say, it applies to a rule in the double ureter with a double collecting system. So, in the Weigert-Mayer rule, doc, the upper pulmo usually descends medially and inserts inferiorly in the urinary bladder, while the lower pulmonary, doc, it descends laterally and inserts superiorly. So the superior pulmonary is prone to obstruction, and the development of urethrosil. Okay, di ba? It's superior at batasan, di ba? Yung superior inferiority complex nga ni, di ba? Mahilig mong bara, mahilig mong obstruct. Well, the one, okay, the lower pulmonary is uretero-vesical reflux. So don't forget about that, because it will appear in the board exam. It appears usually, the Weigert-Mayer rule. So don't forget, doctor. So therefore, what are, doctora, so this is the urethra, doctora. This is the urethra. What are the urethra daw is divided into two, anterior and posterior urethra. Yes. What are the parts of the anterior urethra, doctora? What are the parts? You have here the penile urethra and then the bulbar urethra, doc. What are the parts of the posterior urethra, doctora? The membranous, and then the prostatic urethra, Doc. Ha? Okay, ha? Don't forget about that.
Yes, Doc.
Okay, next. Next. So this is the penis of the patient. So they're actually examining the posterior urethra of your patient here. Anyway, but just for example, I just would like to show you for something lah. So this is the urinary bladder here portion.